Coming to cystitis, it is the inflammation of the bladder mucosa. Um, and etiology, like it is a surgical and the medical. Surgically, there is foreign body calculus growth and urethral obstruction or a psychourethral reflex. And in medical, there is neurological conditions which is to defect in emptying of the bladder, and then we have diabetes, which increases the risk of urinary tract infection. This every that is surgical and medical etiology leads to the defective emptying and causing it stasis, which in turn also increases the risk of UTI. So then we have types such as acute and chronic. In acute we have pinpoint hemorrhages, submucosal edema, pale mucosa, or ulceration. Again repeating: pinpoint hemorrhage, submucosal edema, pale mucosa, and ulceration. In chronic we have fibrosis, which leads to decreased capacity and decreased distensibility. Okay. Then we have classification of it, which is aseptic, you could say, right, instead of a bacterial, tuberculosis, and then we have interstitial cystitis. And in aseptic there is no bacteria, only pyorrhea, that is sterile pyorrhea could be, and the reasons are the TB, malignancy, and a bacterial cystitis. And, turbiturin with sterile pyorrhea is the findings here. And we have tuberculosis, which is secondary to renal TB. Tubercles on the mucosal surface, periorificial hatho, and the pulled up orifice could be seen, which is a golf hole ureteric orifice. We have orifice such as there are 0, 1, 2, 3, 0 grades for normal, 1 grades for stadium, and 2 grades for I don't remember, but 3 is the golf hole ureteric orifice. And this tuberculosis secondary, which comes from secondary to renal TB, leads to thymmal bladder. Management of it is ATT, that is antitubercular therapy, is the mainstay. In the interstitial cystitis, there is elusive also vaccine and waning pain. Then also bleeds on touch in zone of inflammation, increases cough recurrence, and lead to augmentation